Confident Stock podcast is brought to you by My Evergreen Med Spa. Located in Houston in the Woodlands, My Evergreen Med Spa brings to you the latest aesthetic treatments in the most luxurious environment. Remember, My Evergreen Med Spa, it's me time elevated. Welcome to the Confident Stock Podcast. I'm Dr. Rednam, and as you know, I'm a board-certified plastic surgeon in Houston, Texas, also known as the Confident Stock. We decided we want to do something a little special, and we're going to be sharing our top 10 episodes of this year. It's been an amazing year, and I think you guys will really enjoy these as much as people originally had. So you brought up labiaplasties earlier, yes. And I would love to talk more about this because this can be a really taboo or embarrassing topic for a lot of women, but so many women have concerns and they don't know how to address and ask about them. So tell me a little bit about how do people find you for this and what exactly does the procedure involve?
Okay, so labiaplasty is a procedure I do a lot of. Some weeks we'll do one and other weeks we'll do 4 or 5. And I think I only saw one in my training, so I actually didn't know that much about it. I had been in practice for several years and I got a call from one of the older male plastic surgeons in town who called me. He's like, "Karen, I'm sending you my patient, something to do with a vagina. I said you take care of it." And I went, "Oh, okay, there's a need." So, I reviewed the techniques. I made sure I got up to speed. And my first patient, I think anytime as a surgeon, if it's the first one you're doing in practice or the second or third, or even like the 50th, I think it's really important just to be very upfront and say, "Hey, this is a procedure I feel comfortable with, but I want to let you know I don't do a ton." Anyway, the technique that I do is called the trim technique. And I say it's kind of like trimming your bangs, but down there. Many patients don't even know what the name is for labiaplasty, but what they know and what they experience is that they're uncomfortable. The labia minora, which is the inner lips of the vagina, hangs longer and lower. It bothers them if they wear tight pants, yoga pants, sometimes even a bathing suit. They're worried if they cross their legs, the tissue might slip out. Sometimes they have discomfort with sex. Sometimes it's with athletics. And other times it's purely aesthetic. They say, "I don't like to look down there and see the tissue hanging out." So I say a labiaplasty is either for functional concerns, meaning they want more comfort, or it's for aesthetic improvement. But the goal is just to trim the excess, the part which is more darkly pigmented and has an irregular cobblestone-like texture. We don't want to take away all of the labia because it does serve an anatomic function. It's there for normal lubrication and it's there to prevent friction. So the part that we're going to keep is up higher. It's more smooth and shiny and more light pink in appearance. And we do this procedure awake under local anesthesia. We always prescribe an oral anti-anxiety pill for our patients, one the night before, one the day of. We have inhaled laughing gas for them to breathe. We have an all-female team, a nice warm bed in the operating room. We play whatever music they want to listen to in the background. And I think once patients know this is a very routine procedure for us, we're going to make sure they're really comfortable. Yes, we will inject numbing. No, that won't feel good, but probably only for a few seconds. We use a combination of short-acting numbing mixed with long-acting numbing. And once the numbing is injected, they're all good. And they end up chatting with us. We have several members of our team in the room, all women. And they say, "You know what? That was kind of fun. I just felt like I was chatting with girlfriends." And so the trim technique involves just trimming the excess. We have a little grounding pad on patients, and we use a little electrocautery pen to zap blood vessels. And we suture everything together with 3 layers of dissolving stitches, so they don't need to have any sutures removed. I recommend 1 week off work, 3 weeks before exercise, and no submerging in water for at least a month. And most patients are happy, but they're happy in a way that you probably wouldn't expect. They'll come back at 2 weeks for a really quick check and it's still swollen, maybe bruised. And they're like, "Oh, it looks kind of weird." I'm like, "Yes, it does. If people don't look, we'll show them with a handheld mirror right when we're done." Mm-hmm. And they'll say, "Oh yeah, it looks great." I say, "Okay, next time you look, it'll look ugly and swollen." But then they'll come back either at 6 weeks or 3 months And when I say, how are you doing? They're like, oh, I've been meaning to look and tell you how happy I am, but I keep forgetting. And I say, that is so awesome, because if it falls off their radar and if they're not really aware of that body part, if it doesn't bother them
Uh-huh.
anymore, then we've done a good job.
Exactly. And I think that for a lot of women, there's no perfect normal, right? There really is no normal, but like everybody has a feeling of what normal feels to them. And so it's like you're achieving that for them, and they're so happy. It's a
Yeah.
wonderful
Yeah.
feeling.
And like, they don't want to look like a porn star or anything like that. They just want to not be bothered by it. And so
Yeah.
if we can help them achieve that with surgery, and again, surgery is not for everyone, then it's such a great procedure.
What you choose is not something you have to stick with for the rest of your life. If you do implants and you hate them, or if you have bad radiation contracture, we can do autologous in the future. If you do autologous and it's not voluminous enough for you, we can add implants. So I think that that's a really important point. And then also, their decision about what's best for them might change over time. We're seeing all these young women now with breast cancer who haven't even had children yet. So is doing an abdominally based free flap the best option for them? Probably not, but it might be a really great option when they're 45 and done having children and have a little extra abdominal fat. So I think that it's dynamic for each patient, and it really does change even year to year and where they're at in their just life and journey.
And I love that you mentioned that, because we are seeing younger women, and you're right. We've always talked about, well, belly's great, but not everybody's at that. It's great maybe when you're later in life, and it may not be the initial best option. I had somebody who literally, from a timing standpoint, did not have enough time for the recovery that was required with autologous. So 2 years later, the plan was always that's what she wanted. We did implant based, and we came back 2 years later when it was something she could schedule, and she had less anxiety about it. So you don't have to stick just because you pick one choice now. And I think there's not a lot of misinformation about that, or even not enough education, is that you are allowed to change. Once you've had breast cancer, you are covered for your lifetime for what your reconstructive needs are.
Yeah, that's so true. And, I think that it sometimes surprises me that patients don't know that it's covered by insurance. We just take it for granted that everybody knows that it's covered for their lives. And, people will come in and say, oh, I like the idea of implants, but I can't afford to have surgery every 10 years. So I think that's a really important message to give to patients. But to your point, a lot of patients can't even financially afford to take the time off that's required for autologous reconstruction. If you're providing for your family, but maybe in the future, that's something that would be more financially doable for the patient and their family.
Can you explain a little bit about what migraine, like who's a candidate for microsurgery, and like how do you actually treat migraine surgically?
Yes, and I'll just start with a small anecdote, because the first time that I heard Dr. Austin speak to us, I didn't know anything about migraine surgery whatsoever, and I was your typical, chief resident at the time, about to graduate. I have my mind set up, so here's another person talking to us about something I'm not interested in. I'm sitting in the back, not paying attention, but then he is so charismatic, and then eventually we got to talking. Basically, it's occipital neuralgia, which acts as a trigger for migraine surgery, for migraine attacks or headaches. And what we do is similar to what a lot of plastic surgeons do with peripheral nerves everywhere, like carpal tunnel, like tarsal tunnel, like pudendal neuralgia, is decompress the nerve. So, you have the pair of nerves in the back of the head, greater occipitals, lesser occipitals on the outside. And these nerves can get compressed due to one of many reasons, and scar tissue, previous trauma, previous surgery, and because of that they can actually act as a trigger for migraines. And unfortunately, a lot of people, including doctors and even plastic surgeons, just don't know about this. So I'm always trying to get the word out.
Well, because like you said, like not a lot of people know that that's the trigger for it. How do you know that you may be a good candidate for the surgical release?
That's a great question. So I think it starts with just identifying that that's actually the problem. So the diagnosis, that's the biggest obstacle, because a lot of patients, 3% of all ER visits annually are headache related. And so that's the number in the millions. And of those, some studies have shown a quarter of those can be occipital neuralgia. So typically, it's pain that starts in the back of the head and radiates both upwards and to the side. And, we always want the patient to be evaluated by a neurologist, make sure that there's nothing else going on, have the appropriate imaging, whether it's CT or MRI. And then eventually we'll do a nerve block right on the greater occipital or lesser occipital. And if they respond well, that usually means that this is actually what it is, and that's the nerve involved. And some people choose to get Botox, which is a temporary relief for that. Some people take muscle relaxants, some other migraine medications. But if someone's a good candidate for this, then the surgical release can be a permanent solution for that.
Which is just amazing. That could be a very life-changing surgery for somebody. So you said you really sounds like it from an early time you're really
Yeah.
drawn to wanting to be able to take care of women. So
Yeah.
why? Like what drew you
I'm
towards that?
I'm such a girl's girl. I always have been. Since I was a kid, I've always had a group of female friends. To this day, I always have groups of female friends. I and it's something I've always enjoyed. I was in a sorority in college, and I I know about myself that I always knew about myself that that's something that would make me happy in the long run. And there's nothing wrong with taking care of male patients. Lots of people do it, but the way my practice works now is that I take care of all of these women who in another situation could have been my friends, and it makes my practice, it makes my clinic really fun. The crossover between my friends and my patients is pretty fluid, like friends become patients and patients become friends all the time. And that makes the job fun. And so I always knew that about myself, and the practice that I ended up building sort of reflects that core value of mine. And as I've gotten more successful through time, I've really tried to channel some of that mission into other ways to help women that aren't as far along as I am. So last summer, I started this networking group called DC Female Business Owners Networking Group. And initially, I had just put this call out on social media saying, like, hey, like other female business owners in DC, are you interested in networking? And the response was just tremendous. I mean, unbelievable, pouring in of responses. And so then I just started this Google contact form. I mean, it was all very ground up. Started this Google contact form, and I said, if you're a woman and you own a business in DC, and it's not medical, not surgical, just any business, sign up, and then we'll see what we can do about putting together some events. Because at the time when I got interested in that, I had done a bit of a deep dive into women who own businesses, and um, there's all these statistics on how like 50 something percent of businesses are owned by women in the US, or more, 60%. But though all those businesses together generate like less than 10% of the revenue of like global revenue. Yeah. And there are a number of factors, but probably the main one is that women tend to own businesses that are lower dollar value. So women tend to own, nail salons and hair salons and childcare facilities. So the revenue is not there. And then for the women that are building these bigger businesses, there are all these barriers. There's a lack of access to networking. There's a lack of access to capital. And so those are the kinds of things that on a ground level, I wanted to see if I could do something about. I can't solve every problem. I can't make, maternity leave universal, right? But I can create a community of business owners that can share their struggles and can make entrepreneurship a little less lonely. So I started that in the summer of 2023. We started doing these quarterly events, and each event would be focused on something that a woman who runs a business would need help with, like marketing, for example. Or we had one where we had a panel with a small business accountant, a small business attorney, and a small business consultant. And they each gave their like top 10 tips I would give to, business owners, and answered questions. This year so it started growing. We're doing these quarterly events. And I tried to keep the number of attendees around like smaller so that it was a little more authentic. So around like 30 women at each event. And I find that if you have an event with 100 people, you just end up gravitating towards the people right? But if you have an event with 30 people, there's a real likelihood that you'll connect with somebody that you wouldn't have otherwise connected with. So we started doing these quarterly events, and they got very popular, and the list grew, and the list has a couple hundred business owners on it, and the events are still going on. And so this year in 2025, I finally put together a small board for it with a few other people who can help, put together and promote the events. So our next one in the summer, our next one is in the spring, and that one is a woman who built her business and then sold it to Utz, the potato chip company.
Yeah,
And
yeah.
then in the summer, Susan Tynan from Framebridge is going to come and talk to the female entrepreneurs. She's about her whole journey, like how she started, how she got serious funding, how she ended up building this national, I don't know if you've heard of Framebridge, but it's a big deal around here. So anyway, so that has been a really cool passion project. Nobody makes any money off of this, but it's just a great way for me to be able to channel that same energy into something that's beneficial to other women.
I think like we people really don't ever want to talk about the finances of medicine, but like let's talk about the finances of medicine, right? When you're employed, you just get paid a salary. Everybody thinks that doctors have their hands in the money pot and that the doctors decide, no, we don't. We literally work for the man and they determine how much they're going to pay us. And they are the ones sitting at the table negotiating with the insurance companies on how much they think we should get paid. And the worst part is they will often sacrifice our reimbursement, the professional reimbursement, in order to make more on the facility side, which is the hospital reimbursement. So what we're seeing over time is a devaluing of physician reimbursement. So I knew that I was doing 3 to 4 bilateral flaps a week. So that's like 6 to 8 flaps. And I knew how much money the hospital was making because I asked for the data. I said, give me my collections data. And I looked at it and I go, well, just imagine that all those professional fees were going into my bank account instead of the hospital's bank account. I'd be a lot better off, huh? And the thing is, what's so funny is like what you hear back from everyone is, you're doing great. Your husband's a doctor. You live in LA. And it's like, it's not about that. Am I getting what I deserve for the work that I'm putting in? Am I getting back? Or is some other man eating that paycheck? And the latter didn't sit well with me. I'm lucky. My husband's a professor at UCLA. He was doing well for himself. It didn't really matter if I worked or not. We were in a position financially that like, it's great that I was earning an income, but I didn't have to, because for the whole time that we've been married, my husband's been out of training and I was in training. So I just decided like, I'm unhappy with my work environment. I don't think I'm getting paid what I'm worth. I don't think any other academic setup is going to give me the same. So you know what? I'm just going to go out on my own. And if I make it, great. If not, like, I'll go into real estate or be a really fantastic stay-at-home mom. Whatever it is, like, I'll figure it out. And I had to make a critical decision of, am I going to be in network or out of network? And I, at the same time, was really watching the insurance companies really destroy physician reimbursement, especially for complicated surgeries like microvascular surgery. And I kind of felt like, I know I'm so pretty young, but there's a reason I'm so busy. And it must be because I am really good at this thing that I do. And I'm doing all these complicated flaps that other people aren't doing. And I'm taking on these hard cases. I deserve to be reimbursed for it. So I decided to go out of network and I've never looked back.
So I got to ask you a little bit. I mean, a lot of people may recognize your name from being on 1,000-Pound Sisters. How did you get involved with that?
It was a little random. Many years ago, again, I'm dating myself. This was before Zoom and the days of Skype. Someone had reached out to me from the Discovery Network about a new show that they wanted to do about surgical weight loss in families. And I contemplated. I wasn't convinced that I was going to do it, but I did some interviews. And long story short, at the last interview that I did, and they were all excited and asked if I had some recent examples. I said, yeah, I just did a husband and wife this week and two sisters about a month ago. And they said, okay, but do you have any that don't speak anymore or that are now divorced? And I said, you know what? I don't think I'm your guy.
Yeah.
So I let it go. And then I guess it was right around 2019-ish. It was before COVID hit. My office manager said, hey, somebody from Discovery Network called and they want to talk to you. And I'm like, yeah, whatever. And I threw it on my desk.
Yeah.
And about a week later, she's like, did you ever call them? And I said, no, I did not call them. And she said, you should call them. And one lady in my office, she said, I wonder if it's about the 1,000-Pound Sisters. And I'm like, who's the 1,000-Pound Sisters? But they're from Kentucky. And my staff followed these ladies on YouTube. So I called and sure enough it was. And they had done some research on me. I was pretty resistant. I really didn't want to have anything to do with it. Nothing against them. I just didn't want it to get in the way. And I'll be really honest with you without stepping on anybody's toes. I wasn't really happy with the narrative at that time of obesity and weight loss surgery on TV. I felt like that a lot of the times the shows were more about demeaning the patient or belittling the patient, and at their expense of why people were tuning in. And it really wasn't bringing the humanizing element of like what they were going through too. And I remember sitting down with my CEO at the time because there was going to be some legal paperwork that had to happen if we agreed to do that. And he said, I told him that same thing. And he said, well, I guess the only thing that I would say to you is I understand where you're coming from, but what if you have the opportunity to change that? And I looked at him and I said, you know what? You're right. And so for that reason, I'm going to do this. And I guess the rest was history.
Yeah. Well, and the show has become an inspiration for a lot of people. So I think you've done a good job with it. And I think they've done a good job with it at making it something that's really focused on health rather than, and there's fun. Obviously, they're hilarious. But it's, but it's really done a good job in focusing on the right things. And I know for you, an important part of taking care of patients is also taking care of their mental health. So how do you balance that, especially with having people who aren't necessarily always going to be able to come into your office?
Sure. So I talk to them. They all get my phone number. It's the same number that I'm calling you on right now. If they need to message me, they can message me. If they need to call me, they call me. We do FaceTimes, like anytime they need me, and we go over stuff. And I tell them, these are the things you're going to experience physically, but also somewhere around, day 4 to day 12, you're going to lose it. You're, like mentally, you're just going to be like,
what did I do?
I can't do that. Like, I'm ready to be better. I want to be done feeling crappy and being sore and waking up, 12 times in the middle of the night. And I say, hey, listen, this is what we talked about. We said it was going to be tough. What I tell patients is the first week sucks. The second week sucks a little bit less. And
that's spot on. Yeah.
I say those words. So and if they're like, boy, that first week was tough. I just say, listen, I never told you it was going to be easy. What do I always say? And they say the first week sucks.
Yeah. Yeah, and it does. But most things we want take a little bit of time sucking in between there. What are some other things that you feel like are unique to what you do for your patient success?
So, it's that. It's just repetition. It's telling them, hey, this is what you're going to expect the next 3 days. This is what you're going to expect in the next week. This is, and when they see that, they're like, oh, okay, he knows what he's talking about. And it's that, and we help them. And, it's from the get go, folks. I had a woman who's coming in from North Canada. I can't remember one of those. Like Alberta. Is Alberta far west?
All Canada's North Canada?
I think it's Alberta. But she's like way up there.
Yeah.
And I had to this is the area you're coming to. It's part of it is pretty rural. We can help, these are the hotels that I've vetted. These are the Airbnbs that I've vetted. And you're going to come in and this is what's going to happen this day. And this is like, and I talk them. They have the initial consult, and then they have a pre-op consult within a month before surgery. Usually it's a couple weeks, and I say, this is what I want you to do between now and the day of surgery. We're going to then talk about the day of surgery and then the first week after surgery. So, and it's just we go over that, and my staff knows as well because they do a lot of the same thing a lot of times, and so staff training is also super important.
Right, because they're an extension of you, and you want everyone to feel like that. No matter who's taking care of them, that like they're getting the same care you're giving them. Right. So, tell me a little bit about your approach to facial rejuvenation.
So, I am a big fan of what has been coined in the media as the undetectable facelift look. And to be fair, if you have waited a long time and are having a facelift, then it's probably
It's not gonna be
undetectable. But I think when you see, and we don't necessarily want to name celebrities, but these like beautiful, like glow up transformations of women who are in their 40s, let's say, and you're just like, wow, they look
like they're so rested.
Great. They're so rested. Like, did they have a spa weekend?
Yeah.
That, I think, is the power of the modern facelift done well. And it could be facelift, brow lift, eye lift, some very tailored, customized set of surgical and maybe even non-surgical interventions to address all the components of facial aging, but we do it at an earlier entry point so that it's not so obvious. In fact, undetectable.
And I mean, right before it used to be like, well, wait till you look bad. Wait till you look rough and then do it. But you're right. And we're not only just maybe doing that surgical intervention earlier, but we're also doing a lot of other smaller things. So we're doing better maintenance too.
Yes. And it's comprehensive, right? Like you and I, we don't just talk about the surgical components. We want to make sure the skin is on point. We want to make sure your maintenance plan going forward is going to be great. You're still using your neuromodulators and toxins. All this new regenerative medicine is really exciting. We can talk about that too. But I love the use of, again, restoring facial fat. We want to restore volume where needed. We want to truly lift what gravity has descended, and then meticulous focus on scars so that we have a durable, really elegant and understated result.
Hopefully you can wear your hair up and you really can't see.
Yeah.
That's really what people want, is to feel comfortable, not to have that be the focus, but just how good you look be the focus.
Yeah.
What's also changed a lot over time is we used to just feel like I said, it was one component. We just pull the skin and we're looking good. But we know, like you said, there's multiple components. We know it's skin quality, it's volume changes. So I think we're getting better in plastic surgery in all areas of the body, really focusing on it's not just one thing.
Yeah. And then when you don't try to treat everything with just one, that's when we can have these really lovely, really elegant results. And so I think we've really figured out the different components of aging well as surgeons, and we're surgically addressing those in a much more effective way.
Well, and now I'll ask you this. So I always like opinions when people do a lot of facelifts, but everybody has their own. And I can't tell you that there's necessarily one right or wrong answer to this, but there's always the debate. Deep plane versus doing it over the periosteum versus doing SMAS. So what's your preferred technique and why?
And it may vary patient to patient. I'm doing deep plane right now, and patients ask, "Are you going to do a deep plane?" And I'm like, "Yes, I am doing a deep plane." But do you know what that means? What that means? And I think you have to meaningfully lift the deeper like the SMAS layer, whether you're going under or tightening it. I mean, I was so impressed at ASAPS by one of the lecturers who presented just SMAS plication. I mean, it was unbelievable, the results. And I was like, those are really beautiful. So I agree that I think it's the quality of the surgeon, patient selection. But for me, I found that I get a more powerful lift with the deep plane. So when I transitioned to that, I became a lot happier with the durability, I think, of the results.
Will you explain to our listeners what we mean when we say deep plane?
Yeah. So the original facelifts, way long ago, were just taking out skin around the edges and just tightening that, and
which is why people look the way they
and it looked so bad. The scars were terrible because the tension was all on the skin. And then what would we tell you if you were having a big mole or a cancer cut on your face? Don't worry, it's gonna be really, really tight. It's gonna relax. It's gonna just take a couple months to relax. Yeah. But then we're like, oh, your face is gonna last 10 years. No, because it's the same thing. So in some capacity with your facelift, if you're gonna have a longer term result and a nice result, you have to tighten the deeper structures of the face. That in the skin just needs to be lightly draped back, and whatever extra there is will go. So that structural component of the face, we call the SMAS, the superficial muscular aproneurotic system. We don't say that. We call it the SMAS because it's just way too long. But that's where all the debate comes in. How do we do it? How do we reposition it? Do we go vertical? Do we go vertical and back a little bit?
And this can become a very heated argument in the right room of people, the right population.
Oh, yes. And there's people, this is like a very black and white.
Yeah.
And the reality is there are people on polar opposite sides of like how you manipulate that tissue, and they can have really lovely results. So I think that's where like surgical skill and understanding anatomy and that comes into play.
What are some things that you are excited about in the medical space
right now? You want general areas or specific type?
We could start general and let's get specific.
All right. All right. General. I mean, right now, a really hot topic. AI everything. So it can be a buzzword, so you got to be careful because people will label it AI and it's not really AI. I have my tech friends and computer friends who are like, that's not AI.
Okay.
I'm like, fair enough, which is why I get you involved to evaluate these because I have the physician aspect, but I have no idea on the machine learning. I get experts from that to review that. But yeah, AI as a buzzword is very important, hot right now. And just AI is great at seeing patterns. So physicians are great at seeing patterns.
We are.
But AI, I mean, as you get more and more data for AI, they're, amazing from chest x-rays to spine to EKGs. They're just able to pick up those patterns that, hopefully a specialist can pick up. But there's one company I'm invested in. They'll use AI for the spine, for example. They started off proof of concept on the spine. They had orthospine, neurosurgery. Like 30 different orthospine and neurosurgeons review the same imaging. Like almost every single one had a different opinion.
Yeah.
They had the AI review, and then they all came back together and came up with a consensus.
Yeah.
And after that, the AI actually outread the board-certified spine docs and neurosurgeons like 40% of the time. I'm like, that's pretty impressive, right? And you're seeing good data on EKG reads, chest X-ray. So it's going to go throughout, radiology as well as maybe some other.
Well, I know, you've met my husband, who's a pathologist, and I know AI is coming for pathology because that is a huge pattern recognition job.
Yes. Yeah. And that's something that, so patterns as well as, hypothetically, potentially could be done remotely as well, depending on how those images are sent. But that's a great point. I haven't seen anything specific to pathology, but I can only imagine it's coming for that.
He's been watching it. He's like, I don't think I'm gonna have a job very much longer. How many women would you estimate worldwide have had augmentations with Motiva implants so far?
So we actually have very good estimates on that. So more than 2 million women. There are more than 4 million implants globally. So when you add on, like what we do in reconstruction, what we do in aesthetics, so we're talking about more than 2 million women over the last, now almost 15 years.
That's amazing. And I point that out because I know a lot of people are like, oh, they're brand new. Well, no, they've been around for a while. They're just new to us here in the U.S. And as for a silicone implant new on the market in the U.S., there hasn't been anything since 2013, which is pretty impressive to kind of be the new player in the game in the U.S. How did you two decide that you wanted to do this, right? This was no small undertaking to say, hey, we're going to start from scratch. What inspired you to do that?
So in my case, I come from a family of plastic surgeons, and I was always kind of like part of the family business. Although I was trained as an economist, I was always in the operating room with my parents, taking care of patients, as a secretary, all these different roles. And once you understand the journey of patients in breast aesthetics and breast reconstruction eventually, and you realize what plastic surgeons have to go through and how, at the time, they basically didn't have the right technology. So they had to make up for the lack of technology with their expertise, their artistry. So, I think the basis for Establishment Labs is, if we could give, a woman's health angle to technology and bring you technology from the 21st century, then actually technology will be on your side. And this way you can deliver better outcomes for women.
So that all thinking about like, oh, this has been working for 20 years, not necessarily it's valid for these times. I think that it's important to challenge and to accept new technologies as part of a healthy evolution and be part of it instead of pushing it back.
So what did you guys think? Those were pretty amazing, right? I have some awesome guests, and there's just more that are going to come with more time. If any of these caught your eye or your ear, make sure to go and listen to the full episode. And if you enjoy it, leave us a review.